This is actually a trial that we started quite a long time ago, and it was designed to evaluate the relative efficacy of novel microtubule inhibitors given in a weekly schedule compared to the standard, which was paclitaxel. At the time, bevacizumab was a standard of care as first-line therapy for metastatic HER2-negative breast cancer based on the results of ECOG 2100. So our control arm was weekly paclitaxel, 90 milligrams per meter squared, 3 weeks on, 1 week off, with bevacizumab. And then if patients had responding or stable disease after 6 cycles, which was the 4 week is a cycle, they could stop the chemotherapy and continue on with bevacizumab alone. Our two experimental arms were weekly ixabepilone, which had been approved based on efficacy in taxane-resistant disease as well as superiority in combination with capecitabine, but it was given every 3 weeks and quite toxic. So we were evaluating weekly therapy, same schedule, 16 milligrams per meter squared, and the second experimental arm was Nab-Paclitaxel, and a randomized phase 2 trial conducted in Russia, published by Bill Gradishar, had shown improved efficacy with 150 milligrams per meter squared compared to both paclitaxel and compared to every 3-week paclitaxel and to docetaxel. So the idea was that we would study that dose, which we did with each experimental arm was compared to the control rather than to each other. So we plan to enroll 900 patients with the primary endpoint of progression-free survival, but we had interim analyses for futility, and at the first interim analysis the ixabepilone arm was closed for futility, and at the second interim analysis the entire study was closed due to futility. And as one would expect, at our first presentation of this data in 2013 at San Antonio, published in the JCO in 2015, we showed that neither arm was superior to paclitaxel, that the Nab-Paclitaxel arm in particular was associated with increased hematologic and non-hematologic toxicity, including neuropathy, both motor and sensory. We don't usually see much motor neuropathy. We also found that the ixabepilone arm was actually inferior for PFS, and that neither arm showed any difference with overall survival. So we actually had an additional 4 years of median follow-up at this time, and we looked at the overall results, which continued to show inferiority of the ixabepilone arm for PFS, but also now for overall survival as well, and showed similar results for PFS and OS with Nab-Paclitaxel. No superiority, numerically a little bit less. We also looked at the subsets based on hormone receptor status, hormone receptor positive, HER2 negative, or triple negative. And what we found was a significant test for interaction between Nab-Paclitaxel and paclitaxel for hormone receptor status, and no significant interaction for ixabepilone for both progression-free and overall survival. When we looked at the specifics of the subset analysis, we found a trend towards superiority of Nab-Paclitaxel compared to paclitaxel, and the triple negative group only. Interestingly, in the hormone receptor positive group, which was a larger group where we have more power to detect significance, we found that both Nab and ixabepilone trended towards being inferior to the paclitaxel arm. The same was true for overall survival, where ixabepilone was inferior. Nab-Paclitaxel was trending towards inferior for overall survival in the hormone receptor positive subset, but actually was numerically quite superior at 21 versus 15 months for PFS, favoring Nab-Paclitaxel in triple negative breast cancer. Quite intriguing. We continued to show that there were more dose reductions and dose discontinuations for the Nab-Paclitaxel arm, which is concordant with the increased toxicity.